So thank you very much again, dear colleagues and friends, and thank you very much for the invitation. Thank you for joining. It's a great pleasure to be back, and I hope to see you soon in Kyiv, and please stay safe. In my presentation, I will talk about a topic which has certainly not gained so much interest over the last years, but it has been recognized as more and more importantly for patient outcome, but also for the well-being of all healthcare personnel involved in the operating theater or wherever the workplace is. And this is the noise in the operating theater. So let's have a look. We will discuss noise, but also communication, and see where we end up. And I hope you will get some new information on this. So first of all, I do not have any conflict of interest. In the next minutes, I will talk about the noise in the operating theater, mainly about in the operating, the perioperative field, and we'll also discuss how to improve communication in the perioperative field to improve also patient outcome. Before we talk about noise, we should be aware that decibel is a logarithmic ratio with regard to the sound level, starting at 0, which is the lowest sound pressure level we can detect, and decibel in A is measured according to the perception of humans. So let's start with noise. It was Florence Nightingale which mentioned some years ago that the unnecessary noise is the most cruel absence of care which can be inflicted either on sick or on well. So already 150 years plus ago she detected that noise is something which we should take care of and avoid when we treat patients. The recommended noise level in general by the WHO, so the World Health Organization, is just 30 decibel. However, at the working place, we often are able to measure, and we have to experience 80 plus, also almost 120 decibel. I will show you that this has some healthcare implications. Especially during neurosurgery and orthopedic surgery, which is surgery where a lot of mechanical equipment is used, which is quite noisy, the noise level may be very high during most surgical procedures. And this noise pollution is generated mainly by surgical equipment, but also by staff which does not act appropriately. Think about the dropping of glass bottles in the OR, which creates, or also an intensive care unit, which creates some very unpleasant noise, high-pitched noise. And interestingly, over the day, this noise level tends to increase. So on this scale, you see where noise is still considered to be safe, or putting patients and also personnel already at risk, or where we know that is certainly dangerous and also may cause some irreversible damage. Quite often during surgery, as mentioned before, we may reach above 80, but also above 110 or 120 peak noise level. And as you see here, within a few minutes, this may cause some unpleasant and also dangerous noise levels, which may have some health implications within a few hours or even a few minutes. So it is not recommended to have, for instance, a noise level above 75 decibel on a medium-term average, because this is implicated with negative health issues, especially activation of the sympathetic zone. Predisposing factors for being more affected by health issues coming from noise is age, other pre-existing illnesses, and also the cumulative dose of noise over lifetime. Tinnitus and hearing loss has been described often in anesthetists. So 2/3 of us at some time in our career will be affected. And interestingly, and this was quite new to me also, because of anesthesia, the inner ear muscles tend to work less, which means that the noise is affecting the inner ear even stronger during general anesthesia than during an awake state. Because noise is considered as a biological stressor, we tend to activate our sympathetic nervous system with fight and flight reactions. Accordingly, patients and also we as healthcare personnel tend to have a higher blood pressure, a higher heart rate, a higher peripheral vascular resistance, and we tend also to develop all diseases related to a higher sympathetic tone more easily, as you see here. So when the noise level tends to be too high, above 85 decibel, the employer, at least in several countries in America and Europe, has to provide and is obliged to provide hearing protection. I've never seen any hearing protection in our perioperative field. Maybe you have seen it, but I haven't. So it seems that we are not well protected against the noise in our environment. And it's not only about equipment, but it's also about training. So this lesson may help to some extent. So where's this noise coming from? To a large part, it's coming from machinery, being part of our perioperative environment. We heard about the orthopedic and neurosurgical procedures, where most of them tend to exceed 80, but also 110, 120 decibels. Because of noise, the information between humans is degraded and we are less able to communicate. Also, the attention is losing out because we have to concentrate to take off barrier of noise, which means we tend to be less hearing when somebody's speaking with us. This may lead to errors based off miscommunication or not understanding. And interestingly, and this is very, very important, those most affected by high noise levels are the trainees, so younger doctors, which have to concentrate very much on their procedures because they had not automated their activities yet, and therefore they are those who are experiences the highest burden, also tiredness in the evening, but also decrease in the quality of their work, which often remains undetected, but may lead to patient injuries. And very interestingly, in this study, also more surgical site infections were noted. So effective communication is important to have a high quality delivery of care to our patients. We are basically working in an expert environment, so lots of experts working together, but they are not working, let's say, side by side with each other, but they are working interconnected with each other. And interconnection means that communication is essential and has to work to guarantee the best outcome. So if communication fails, this may lead to error, and this may lead to an increase in morbidity, but also mortality. And miscommunication is one of the most important events in which could be avoided in surgery. You may have heard and read that up to 80% of the errors made in medicine are considered to be avoidable, and a lot of it is coming down to miscommunication. Several studies showed that the younger doctors are those who are most distracted by noise, and this distraction will increase over time and negatively affect the procedures which are just performed. And again, studies showed that surgical site infections tend to increase immediately, but also are still higher 30 days after surgery in a high noise level environment. Importantly, when you want to understand communication, what somebody's telling to another person, the level of sound of this communication has to be 10-15 decibel higher than the surrounding basic noise level. That means somebody has to talk louder, but has also to listen more carefully to what the other is saying. And so, as you see here in the second line, even with 10 to 15 decibel louder speak than the average environment in noise level, there's only a 90% accuracy rate of what somebody can understand. Because of high noise levels, it has been shown that people tend to speak shorter and to speak less in a high noise environment, and this of course may again inhibit communication between the team members and may lead to a lower patient safety. So we heard that the noise level in the operating theater is high, is already at the level with 80 to 85 decibel on average, which is considered as health detrimental. And because of this high noise level and even a higher level which is required for communication, in this study the surgical trainees, they experienced fatigue, and also the number of errors increased when they were performing simulated laparoscopic surgery. When the same study setting was applied to experienced surgeons, we could not, or these studies could not see any negative effect on these surgeons. But remember, this has been an experimental short-term study, and of course also experienced surgeons will experience over time more fatigue. And we have heard before that the health detrimental effects of noise have a time and a level effect size dependent result, which means that over the years and not within such a short-term study, also high experienced surgeons will of course experience negative healthcare effects. Another study confirmed that the highest likelihood of mistakes and distraction in surgeons comes with equipment failure and equipment difficulties, but the second most likely factor for distraction of surgeons was verbal interruptions. So try to avoid phone calls, try to avoid talking to surgeons and making phone calls to surgeons who are in the operating theater. Try to keep the phone calls away from the surgeons and also from yourself as anesthetists, as this is negatively affecting your thinking, consideration and concentration with regard to patient care during a procedure. Most of the talk made in an operating theater was considered as irrelevant for the surgery. So try to avoid this small talk and keep the noise level down if you really have to talk about small talk during the surgery, so not to distract your surgeons, or vice versa. Surgeons should not distract the anesthetists. Also nurses, of course. So therefore, this verbal interruption should be limited to the most essential to avoid. What about music in the OR? Some say it has a calming effect. Some studies show that it can have a positive effect. Other studies show that it has a neutral effect. But some studies also showed that it has a negative effect. So how can we decide if it is good or not? Well, actually, it depends on the interest and on the taste somebody has for a given music, and of course also for the task and for the experience grade while one is listening to the music. So if you have a new procedure, or if you are junior, and if you don't like the music, that is for sure a combination which is not good for the performance of a given physician. So therefore, ideally, just to keep all the personnel in our OR in line with each other, and to avoid negative effects of music to some personnel, the suggestion is not to use any music at all. So let's talk about communication in the OR. Of course, there are different statures in, let's say, physical statures with the staff, but of course there's also differences in the hierarchy level and in the power people have in the perioperative field, in the OR, also in the ICU. And importantly, to have a good communication quality, we should try to flatten the hierarchy and to make it able for the smaller people in the hierarchy, but also for the larger, to speak to each other in the best possible way. Because this eases communication, and this eases also communicating health issues, healthcare risk issues, health risk issues, which maybe the smallest in the team may detect, and that does tend not to speak up to the highest in the rank because of fear of reprisal. So what are the challenges of speaking up? Certainly, the coming and going of team members from different subspecialties and job groups may be a problem. So in bigger teams, the problems may be higher, the problems may be bigger than in smaller teams where team members tend to know each other. Complex surgeries may increase the risk of miscommunication. The background noise, we heard it already, so the more there is noise, the less there is communication, and especially the less good quality communication there is. This is, as we heard, often related to the noise of surgical equipment, but also because of small talk or people just speaking up too loudly. And of course, if quick decisions have to be made, then it's very important to come to good and quick solutions in communication. Of course, you are aware that anesthetists may have another culture of discussion compared to surgeons. And also within surgeons, there are different qualities of communication. Some may be a bit more harsh, others may be more inclusive. And also different specialties and jobs, professions like nurses versus physicians may communicate differently to each other. To have a good communication, we need a psychologically healthy and safe environment. where we do not have to fear each other, but ideally we should trust and like each other. This is very important for a good and high quality culture. So what is the right environment? The right environment is one where you can speak up freely without the fear of getting psychologically injured, so where it is psychologically safe to speak, where one would not get punitive treatment by speaking up, where one would not have to have fear to speak up, because even if he would say things which are correct, he would get a slap with words. And this requires a very good culture, a very good climate of communication, and this is organizational learning. This cannot be changed from one day to the other, but it has to be top down, so from the head to the top, from the head to the bottom of a society, so starting with the bosses, but also down to the youngest. And of course, the youngest will bring in these new cultures, because this is the zeitgeist, so this is just something which is increasing over the years and decades. It has been certainly strongest in the Scandinavian and English-speaking countries, but is now also transpiring into other cultural and linguistical areas. So the prerequisites are certainly that somebody dares to speak up, dares to say his opinion, and can say that without being slapped or getting a punitive action or retribution. So good interpersonal relations are very important. Trust has to be in place. We have to be also supportive of each other, and we have to be grateful for input by others. And so to develop ideas together is very important. This is all named under the term speaking up. So saying explicitly what somebody thinks and observes, asking for clarifications if there are issues which are not discussed properly, challenge others, correcting each other, and decreasing the power distance. So what is the power distance? The power distance is a very important concept. So as mentioned, in the hierarchy of a hospital there will be a boss and there will be lower ranked team members. And the power distance is basically the might and the power status of the highest in the hierarchy and the lowest in the hierarchy. This is considered the power distance. And the power distance, of course, between these different levels in the team is different. So we have to decrease the power distance between the most bottom ones and the highest ones. Because, as we heard, this will improve the communication. There are several models and tools on how to speak with each other. I will briefly mention a few. They are easy to remember. You don't have to follow them in detail, of course, but more important than using a specific tool exactly, you should be able to understand the general principle of the tools, and they are all quite similar, although they have different names. So there is this concerned, uncomfortable, scared system, which is the CUES system. There's this probe, alert, challenge, and emergency system, which is called the PACE system. And then there's the 5-step advocacy concept. I'll just show you them briefly. So there's a 3, there's a 4, and there's a 5-step approach. Yeah. So the situation is, or the case is that there's a general, very experienced surgeon, the head of department, and there is the young, he's Mr. Smikal, and there is Dr. Kovac, who is a very young resident who just started 3 months ago. And today, Dr. Smikal and Dr. Kovac are going to perform surgery on the right inguinal hernia, and they're going to do this with a mesh repair. And just after surgery, anesthesia induction, the younger doctor, Dr. Kovac, notes that the left side of the inguinal region is marked instead of the right side. So he has to say something, isn't it? Basically, how does the younger Dr. Kovac speak to the far higher, with regard to the power distance, far higher Dr. Smikal? So this is just two persons, so it's a 2 challenge rule. And if Dr. Kovac is not able to talk about Dr. Smikal and convince him, because he's too assertive, Dr. Smikal is more senior one, then the younger one should get in another person who has less distance to Dr. Smikal to convince him that this is the wrong side. So Dr. Smikal says to Dr. Kovac, well, I marked this left side with my nurse, and I'm going to do surgery on the left side. But Dr. Kovac says, or thinks it's the right side, so what do I do? And so Dr. Kovac, because the rule of 2 does not work, Dr. Smikal is challenging him and would do surgery on the wrong side. Dr. Kovac, the younger one, takes in a senior surgery resident, where the power distance between this senior surgery resident and Dr. Smikal is shorter compared to their range, so between Dr. Kovac and Dr. Smikal. And by reducing the power distance, they try to convince him. So I mentioned 3 tools for communication. So there's this concerned, uncomfortable, and scared concept. So the younger one, Dr. Kovac, says to the older one, Dr. Smikal, I'm concerned. And he also says, I'm uncomfortable. Yeah, I don't want to continue this way. And he's also scared. So there's a safety issue. I have to get in somebody else, the more senior surgical registrar. One can also use the probe tool. This is quite similar. So, Dr. Smith, do you know that the patient requires repair of this right-sided inguinal hernia instead of the left side? And he alerts him, can we confirm the site of the surgery? And then he challenges him, saying, we need to pause now. And finally he says, with the emergency, the E part of this tool, please stop the surgery and verify imaging. Check the notes and consent form and re-examine the patient. And there's also a 5-step approach, which is to get the attention of the person, respectfully state the problem, state the consequence of it. Yeah. In this case, the patient could have a wrong-sided surgery. Yeah. Make a suggestion to address the issue. I would like to see the images, please. And let's check also the informed consent, to confirm the site. And finally, seek agreement on the plan of action. It is my plan to check the images before starting, okay? So, to allow persons, especially with a low power in a team, to speak up, it's very important that they are able to speak up, that they are allowed to speak up. This is called the receptiveness and the impact, so that we don't smash them down, And they should also be aware that speaking up has not a negative impact on them. So they have to be certain that they can speak up and that the feedback provided is positive. And then they have the motivation to speak up. So they are allowed, and this is something which is merited, something which gets positive credentials, and positive feedback by the seniors. And there have also been clinical factors in place, so that again, people are allowed to speak up. People have a prior favorable experience from others. This is called the positive reinforcement. I know that somebody had spoken up and had avoided problems in another patient, and I can do this now also. This is positively seen by the older in my team. And the contextual factors are also important. So we have to have a good, very, very good interdisciplinary cooperation. Also within the team, we have to have a good cooperation spirit. We have to have clear standard operating procedures, clear procedures also on how to prevent injuries, and how also to overcome injuries which have happened. So a CIRS, critical incident reporting system, also a good mortality and morbidity conference are very helpful to show that we take these challenges from risks and potential injuries which may happen also if we pay very good attention seriously, and we try to calm down on the amount of negative outcomes for our patients. So we try to diminish them. So if the team knows that we are serious on that we want to get better and better over the year, and we act and communicate accordingly, so people will tend over the years to speak up. So strategies for inclusive leadership are that we invite others to share their ideas. We speak in a language of we, so it's not me and my disciples, but it's our team, it's not my team. We are happy for people to communicate and to participate in speaking, but also in participate in decision making, to some extent at least. And as I mentioned, the psychological safe environment is very important. And we have to make a team spirit where all like to work with each other, and where they try to share their views and what they've seen, because some may see things which others will not see. This can also be trained. This communication can be trained with simulation. That's up to you how much you will be able to go into this. I don't think that too much practice making is so relevant. So to train this, it's more important to have really an environment of trust and respect for each other. And if you have an environment which is like a good family, like a good friendship, where you can openly bring up themes and discuss problems, then you are already on the right side. And as I said, critical incident reporting, morbidity and mortality conferences, and openly discussing difficult cases like performing debriefing, and maybe also discussing difficult cases before you start them, or on a daily basis, also 2 times a day, or visiting the patient together. This is very important. Consider also in difficult patients to rest the weight and the burden not only on one pair of shoulders, so one physician and one nurse, but try to involve more people in the OR during the case, but also later on intensive care unit. So there are some barriers to speaking up. As you see here, the lower position, we heard about that, challenging authorities, which are very dominant, poor communication skills, the noise again, coming from a minority, bad experiences in the past, yeah, or if you are not used to this, if the culture does not exist, if you have not been trained, if you know little, if you just know a little bit, if you don't know the language, for instance, yeah. Yeah, so just go through the list and have some more ideas. I'm sure if you think about your working environment, you are aware of what we are talking about. Reprisals, of course, so experience of the past are very important. You can only change the future from the present, so be sure that from now on you really take this seriously into account. So finally, I would just give you a few examples of what we're doing at our hospital in the St. John of God Hospital, Barmherzige Brüder, BHB, in Salzburg, in the OR. So we try to have a flat hierarchy, we certainly do. It always could be flatter, but at the end, remember somebody has also to make a decision and take the responsibility. We try to live in a role model way. That means like Immanuel Kant said, try to behave as you would like others to behave in an ideal way. The environment should be psychologically safe. We try to support people who speak up and to pay them thanks and attention. I talked already about the SIRS system and the M&M conferences. We have a quality assurance program and a risk management program. We have annual reports, and we have also some external auditing by a company which comes every few years. So when we perform surgery on a patient, we have a sign-in. This is still outside of the hospital, of the OR in the hospital, just in the OR perioperative waiting area, where we check the identity and the site of the patient and the site of the surgery, and make sure that he is really without food and fluid intake for the given time. Check also the allergy status again. Sorry. And then when the patient is in the operating theater, before we start with surgery, we have a so-called team timeout, which is done by the youngest and most junior person in the OR, which is normally the non-sterile assistant in the OR. So basically with high school degree and 1 year of additional training. So we give this checklist to the youngest and to the most junior in team, which is certainly grading him up. And there we ask again for the identity of the patient, and we ask for the surgical steps. And as you see here, different positions in the OR team have to reply. We check for the instruments, we check for if blood products are required. We check for whether all the instruments and imaging required for this patient are on site. We also check if the antibiotic prophylaxis has already been given, or we may also double check whether something special is needed in this case. And then finally we ask if there are some other questions which have not been addressed until now. And only then we start with surgery. If we have a handover in the middle of the case, then we will do this team timeout again in a short version with the new surgeon. We try to avoid this, and this really happens rarely. And finally, we have a sign out at the end of surgery, where we also check for all gauzes and equipment and failure, and where we make a plan for the patient after surgery. For noise monitoring, we have hearing devices, hearing and noise level devices, where we monitor the noise level, and depending on the noise level, this ear may be green, yellow, or lighting up red. So this gives us also an acoustic visualization of the noise level. Don't forget the World Patient Safety Day, which always takes place on the 17th September every year. And last year, noise was communication were also addressed. So in conclusion, we heard that background noise is highly relevant for the given case, but also for long-term outcome. Remember, the 30-day surgical site infection is also affected. We should try to avoid noise made by instruments to cut it down as much as possible, and we should also avoid non-case relevant chatting and disturbation of the involved team during a procedure. The burden is most strongly felt by the most junior team members, and they certainly make more mistakes. Music is a double-edged sword. It may help and stimulate some, but it may be even of a bigger burden to others. So we should try to avoid it if we're not all on the same line. But this needs, again, speaking up. So ideally, just avoid it. Finally, we minimize noise and we monitor noise, as you have seen with the hearing aid. Communication is very important. So everybody has to be on the same side. Everybody has to be able to speak up. So the power distance has to be shortened. The culture has to be made for everybody to speak up. Education is very important, but even more important is to have a positive and culture within the team. And we require a psychological safe environment. Just think about the ideal family where everybody is has the same power, is not prone to physical or psychological violence, and is just happy to speak up to improve the patient care. So that's all. I hope you liked it. Thank you very much for your attention. And if you have any questions, please feedback. Thank you.